Good morning. Today we start our topic of sepsis. I'm sure you have all seen patients that are septic in the hospital. So today we're going to review or take a look at sepsis. Our objectives for today are to define sepsis in your own words, identify causes and treatments, and how to manage a septic patient. So first, let's define sepsis. What is it? So I'll give you a couple minutes here to come up with your own definition of sepsis. And then I also want you to think about the patients you have seen that are septic and what do you think caused it. So I'm going to give you a little time here to take a look at these questions and answer them, and then we'll move forward. So move forward when you're ready. What do you think puts patients at risk for sepsis? Think of the patients that you have seen that are septic. Think about their age. Think about their personal habits. Think about other factors that could put a patient at risk for sepsis. So again, I'm going to give you a couple minutes here to think about what puts patients at risk for sepsis. So typically, the pathology of sepsis can be initiated by a gram-negative or a gram-positive bacteria such as strep or staph. Can also be caused by fungi or viruses. So what happens is the patient gets that initial infectious insult. So they get that first, maybe they get a cut, or maybe they have trauma or something that on that left circle there, that green circle, they get that initial infectious insult. Sometimes it just stops there. Sometimes the body is well enough that it can just heal itself and not go further. So think about yourself. What makes you not go into sepsis when you get a cut or you have some sort of infectious insult? So think about that for a minute. And then if you have more risk factors, like we talked about earlier, if you're elderly, or if you have other illnesses, or if you are a drug abuser or alcohol abuser, those things can put you at risk for a preliminary systemic infectious response. So that's the SIRS, the systemic inflammatory response system. So you can move to that. So if you have an infection plus the SIRS, the systemic infection inflammatory response, that can put you into sepsis. If it doesn't get treated then you can see in that blue circle, then you move into severe sepsis. So you get a preliminary SIRS, then you get an overwhelming SIRS or systemic inflammatory response system. So you get that, and then you can get a compensatory anti-inflammatory response where the body tries to send all its white blood cells right to that source, and then it uses those all up, and then it gets to that severe sepsis because now it has no other antibodies to fight. So you can see on that right side, any of those things can cause a systemic inflammatory response. So the pancreatitis, which we talked about, traumas, burns, any other types of injuries or insults that cause that inflammatory response can lead to sepsis. Here's another look at sepsis. So there's that systemic inflammatory response, either system or syndrome. That's SIRS. So if you ever hear SIRS, that's what that is. It's that general inflammatory response. So we're going to talk about a cytokine storm here in a minute in our next couple slides, but that's what happens. You get all these cytokines that flood that area. The white blood cells flood the area, and then there's an immediate response. SIRS can be diagnosed when 2 or more of the following are present. The heart rate is greater than 90. Body temperature is really high or on the lower end, so you kind of have to take a look at what's going on with your patient. Hyperventilation. I just read a study this week that the respiratory rate now they're saying should be greater than 22 instead of 20. I don't know why they made that specific, but I think they were considering 20 as normal And then, so they wanted to make it a little more abnormal. So now the new standard is saying 22. White blood cell count, this is what we were talking about, either less than 4,000, so the body's already used up those white blood cells, or greater than 12,000. So if it's in the initial state, you might see it really high. We saw a patient not too long ago that had a white blood cell count of around 50. So keep those things in mind. And then in the diagram there, it shows SIRS plus proof of infection equals sepsis. So you'll see the bacterial, the fungal, the viral, the protozoal, plus the SIRS equals sepsis. Do keep in mind too, there's a difference between sepsis and septic shock. We're not talking about septic shock right now. That's when you get down to the multi-organ dysfunction of your system, so you have multiple organs that are failing. That's septic shock. We are just talking about sepsis right now. So here's what happens when I was talking about those cytokines that are released. So this is called the sepsis cascade. This is what happens when you get that initial infectious insult plus the systemic inflammatory response. So these are the two things that come together to make sepsis. So if we start on the left-hand side, you'll see the neutrophil activation, aggregation, degranulation, release of oxygen radicals and proteases. And then above that, you see the activation of coagulation and complement system tissue factor release and the fibrinolytic activity. So then you start having these little clots that form, because your anticoagulation status is no longer in that homeostasis. So you have that aggregation of the platelets that start causing microclots. Okay, so keep that in your mind. We're going to talk about that in a minute. And then you have the bacterial products and components, which starts this whole thing. And you have the release of the macrophages. And then you have the chemical releases and the, excuse me, and the enzyme releases that go on to cause the endothelial damage. Okay, so then you get to the endothelial damage, and what happens there is the lining of the vessels becomes permeable. So then you have that leaking of fluid, and your osmotic and hydrostatic pressures change, and that's when it becomes dangerous to your patient, because that fluid can leak into the interstitial space of the lungs and cause ARDS. So this can all happen with sepsis. We're not to the tissue injury or the organ dysfunction yet. That becomes more prevalent in your septic shock patients. So right now we're just stopping at the endothelial damage, hoping that our patient doesn't go from sepsis to septic shock. Okay, so this is kind of a summary of what I just said. So you have the inflammatory mediators. Remember I said you had all those chemicals and enzymes that are released, which can lead to the change in the vessel tone, that hydrostatic and oncotic pressure, osmotic pressures change, which increases that capillary permeability. So that's where we want to stop it. We do not want to get into the shock phase of this. We want to stop the inflammatory mediators right there where they are. So here's that cytokine release, where you have on the left side, you see the initial infectious insult, and then you see what happens there. That's when all those chemicals are released. You see the cytokine storm, or the cytokine release, which causes the increase in oxygen radicals. You see the inflammatory response, where you get the fevers, the nausea and vomiting, the lethargy. All of those things are happening at the same time. And then again, that coagulopathy problem, where your patient is throwing little clots, or the microvascular clots are happening all at this time. All of this leads to the inflammatory response, anticoagulation problems. Another thing that happens in sepsis is the decrease in cellular delivery of oxygen leads to more extraction from the capillary blood cells. So we have a problem here that puts the cardiac output at risk, because we want our delivery to be really high. Well, when you have these endothelial injuries and you have these cytokine releases and you have all of these things happen, the cells become severely starved. They're not getting the oxygen they should because of all the osmotic and hydrostatic pressure problems, and the blood cannot get to the organs like it should. So that increases the problems with the ATP production because of the anaerobic metabolism, which in turn increases the lactic acid production. So this is a good visual of how we split up our lactic acid problems. Are they hypoxic in nature or are they non-hypoxic in nature? Remember with sepsis, if you have a lactic acid over 4, that is considered high, and then that gives you another clue that your patient is septic. So on the left side, we have hypoxic problems, which are ischemia, anemia, cardiac arrest, shock, global hypoxia, carbon monoxide poisoning, respiratory failure, severe asthma, COPD, asphyxia, regional hypoperfusion, which can be from sepsis, limb or mesenteric ischemia. And then on the right, we have non-hypoxic problems that can help or that can cause lactic acidosis. We have delayed clearance, and they're talking about our renal clearance, kidney or liver dysfunction, and then the sepsis falls into the non-hypoxic category. So that's what happens when we lose our blood flow because of those hydrostatic and oncotic pressure problems due to sepsis, and we lose our tone in our vessels. So that's why sepsis falls into that non-hypoxic category, which can cause lactic acidosis. All right, so what do you think the patient feels like when they're septic? So write down a couple things. What do you think they feel like when they're septic? What assessments are you going to be doing on your patients that are septic? And they can be respiratory or non-respiratory assessments. And then think back to what labs we're going to draw, and then what other tests do you want? So write those all down, pause the video here or pause the PowerPoint here, and see what you come up with. So the best thing we can do for these patients is to prevent it, to stop it at that initial infectious insult. So get your patients to the physician, have them take a look. Education is the best thing. Tell your patients, if you get an infection, get it taken care of. Don't let it go too far, especially the patients we see, like our COPDers that are already compromised, or that have cancer, or that have renal failure, or any of those things that the patient is already compromised. Really educate them and encourage them to get to the physician as soon as they suspect an infection is present. If they do get septic, we need to consider increasing their fluids, consider vasoconstrictors to keep that vessel tone normal, consider inotropes to keep the cardiac output stable, and oxygen, nutrition, comfort, all of those things that are going to support the patient. And antibiotics, that will be the first thing. But education first, and then your antibiotics, and then start with fluids, try to get that infection flushed out, consider vasoconstrictors, monitor their oxygen levels, monitor their nutrition levels, make the patient comfortable, get them back to baseline as soon as you can so that they don't turn into that multi-organ failure syndrome. We want to avoid getting them into the shock syndrome. Mortality rates are pretty high. For our septic patients are 8 to 16%. Once they get into that septic shock, it triples. So we want to get them out of sepsis as fast as we can so that they don't progress into that higher mortality of septic shock. So think about some things that you learned today. We're going to talk about the rest of these in class, some of the questions that I asked you. So we'll continue our discussion in class.